we get a good draft in there for your mentors to review. So guys, today, one of my favorite people in the entire whole wide world is your speaker today. This is a person that I met in my first year of residency. At the time we met, Dr. Brown was a second year resident, and so he was kind of a mentor to me. And then we worked together at the VA, and gosh knows he was definitely a mentor in navigating the federal pharmacy VA system, just navigating as a young professional, working with more seasoned pharmacists, navigating being in Arkansas. I was a transplant. And so he has become just one of my most favorite people in the world. And one of those people that when I call on him, he always says yes. And so I'm appreciative of him being here today. And so today, your speaker is Dr. Zhiva Brown. Dr. Brown is a graduate of the UAMS College of Pharmacy class of 2005. He completed a pharmacy practice residency at the Central Arkansas Veterans Healthcare System in 2006 and began working as an inpatient pharmacist that year. The following year, he also began working as the clinical pharmacist for an inpatient geriatric team. He is a board-certified geriatric pharmacist, and in 2014 was promoted to the position of the inpatient clinical manager for pharmacy service at the VA, followed by then again being promoted to the clinical coordinator for all of pharmacy service in 2016. In addition to his work at the VA, he has also held pharmacy positions in retail pharmacy, long-term care pharmacy, and other community hospitals. He has been active in local, state, and national pharmacy organizations and continues serving the interests of the pharmacy profession. And let me just say, Dr. Brown was one of my preceptors when I was a PGY1. Or PGY2, I think, and he was no joke. We would go on rounds, and Dr. Brown is that one that turns to you and puts you on the spot, and you got to get that knowledge going. You better be ready because he's going to ask you. And so we had a good time. I'm thankful for his mentorship and all the things that he taught me. And this is my people. He's just one of my people, y'all. So I'm excited to have him here. Dr. Brown, I have given you co-host ability so you can share your screen, and I will turn it over to you.
All right, thank you very much. I have not done a presentation before, so I might need a little bit of help.
So the green in the bottom of the bar at the bottom is a share screen button.
Yes. Let's go with share screen.
And then you'll be able to choose your presentation. It should show you all your screens. Yep.
So you can see that?
I can see that. Yep.
All right. Now, how do you put this in presentation mode?
So I can't see your presentation though.
Oh, you can't see it?
I can't see it yet. Oh, now I can. There we go. Okay. Now I can see it. Yep. And then presentation mode on here is go to slideshow at the top.
Yes.
Yep. And then, yep, from the beginning. There we go.
Thank you very much. Oh, how about that? Nope. So what are you seeing now?
I'm seeing your main screen, your main slide, and then I'm seeing the next slide in the notes. So that's fine.
That's fine.
Yep. Or if you would like it to be different, yeah, you can flip it. So how do you flip it? Let's see. Hit the three little dots right there and see what that gives us.
Three dots.
Uh-huh. Right there. Hi, yep, there we go. And then, Oh, I know what it is. At the top, see right at the top where it says use to presenter view, unclick that, go over one more, over right there. Yep. Click that and then take that off. Unclick.
Unclick?
So unclick it. Yep, and then do from the beginning. I don't know why it's doing that.
If you click it again and go back to presenter view and then go to the top where it says go into it, click it again. Yeah. Now go to your presenter view. Yeah, go to start from beginning and see if it'll take you back to presenter. And then when you're there at the top, it says display settings. When you get into it, and I think you can take off next slide display.
Got it.
Well,
Maybe.
I know Nada doesn't want to do it.
okay. Well, we can go from here. How about that? You want to just do that?
Yep, let's do that.
All right. Well, welcome, class of 2024. You all have made a huge accomplishment in getting accepted into the College of Pharmacy, so I want to commend you all for that accomplishment, and I want to thank Dr. White for that fabulous introduction. I think, obviously, she feels honored to know me, but I feel much more honored to know her. So I'll take those kudos, but I'll throw them back at her. So thank you. Once again, my name is Zhiva Brown. I am the clinical coordinator for pharmacy service at the Central Arkansas Veterans Healthcare System. So today, this presentation is to be about clinical pharmacy within the VA. So let me tell you a little bit about what the VA is. So you can tell on this slide, the VA is a tertiary healthcare system. We serve more than 88,000 veterans in the state of Arkansas. And we log over 1.2 million AmCare visits each year. We have satellite clinics in, which are community-based outpatient clinics in Searcy, Pine Bluff, Conway, Mena, El Dorado, Mountain Home, Hot Springs, and Russellville. The VA is divided into two main campuses, the main campus being the campus in Little Rock, John L. McClellan, which is right next door to where you all are, and then the North Little Rock campus where I'm currently hosting this presentation called the Eugene Tobin Healthcare Center, and again, it's in North Little Rock. We have about 280 operating hospital beds. 152 of those are community living center beds. And then we have a domiciliary, which houses about 119 beds for residents in the rehab program. And that's located here in North Little Rock. So what is this picture? This picture is a picture of you all when you found out you got accepted into the College of Pharmacy. So congratulations, everybody. It also represents, it's a picture of some first-year pharmacy residents. And so why did I include this picture in this presentation? One, it's a representation of you as new up-and-coming pharmacists. Two, it's the first step towards clinical pharmacy. So my introduction into clinical pharmacy happened when I was a first-year student, kind of like you all are. I had taken a job in the outpatient pharmacy at the VA and just doing regular technician work in the pharmacy. One day, someone came in with a white lab coat, walking very authoritatively. They went through the scripts that were laying on the counter, found what they were looking for, and turned to me and said, "Hey, can you fill these scripts expeditiously? I really need this. I have a patient who's got blah, 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 blah." I didn't understand any of the medical jargon that she was speaking to me, but I knew she understood what was going on with the patient and she needed that those scripts filled so that she can continue talking to them about their discharge medications. And she turned around and walked out. Now I knew all the technicians in the pharmacy, I knew all the pharmacists in the pharmacy, but I had no idea who this person was with the long white coat being very authoritative. So I turned around and asked one of the technicians, I said, who's that person? And he said, "Well, that's one of the residents." And I said, "Oh, we let medical residents just walk into the pharmacy? They have access to the pharmacy?" And they said, no, that's one of the pharmacy residents. So I had no idea that pharmacy even had residents. So, of course, that piqued my curiosity. So I went around asking, well, what is a pharmacy resident? And so they proceeded to explain what a resident was and why they were doing a residency. And it was to get that extra clinical training, that extra knowledge, so that they could go out and possibly practice in a clinical setting. So I had no idea what those clinical settings were. Again, I was a first-year pharmacy student. So over the years, I gained to learn a lot more about what a residency mean, what clinical programs meant, and where we were within pharmacy at that particular time. Now, as Dr. White mentioned, I graduated from the residency in 2006, so that was a long time ago. And clinical pharmacy has grown a lot since then, and we've got a lot more opportunities for pharmacists in the clinical world since that time. And so I'm going to go over a few of those that we have here at the VA. So we'll start what most people are familiar with, and that's the ambulatory care side of clinical pharmacy. And so we have quite a few positions in AmCare here at Central Arkansas Veterans Healthcare System. And so one of those positions, I'll start here at the top of the page, is our substance use pain management pharmacist. And what their role is, they help with the de-escalation of pain medications for our veterans. And so if you've paid any attention to the news over the years, you've seen that the VA is notorious for having a lot of veterans on high dose opioids, and a lot of opioids are being found out in the community being prescribed from the veterans healthcare system. And so we've been tasked with trying to not have the veterans so dependent on opioids. And so how do we do that? And it's a team effort. There's a pain physician, there's a pain CPS, there are other supportive elements to that team, and they all work together to make sure that they de-escalate medications as best and as safe as possible for those veterans. We have some that have substance use disorders, and so the pain pharmacist helps with those patients as well. All right, the next AmCare position, we have home-based primary care. So you all know what primary care is. For some of our veterans, they are homebound. They can't get up and come into the VA every time there's an issue. And so they have been enrolled in our home-based primary care, which encompasses about 50 miles within the Little Rock area. And so those services are brought to the patient's home. And so a nurse will go out there, they'll draw blood, they'll get labs, whatever they need. And if interventions are needed by the APRN or the physician or the pharmacist, then they can make those interventions remotely. Do the pharmacists go out to the homes? Sometimes they can. Obviously, during the era of COVID, not so much. But if you ever have a rotation with the home-based primary care, then you'll probably end up going with one of the nurses out to the homes to see what happens within that care setting. We also have the pharmacist in our liver clinic. It's also called a transition of care clinic. And so a few years ago, they came out with a bunch of new medications that were used to treat hepatitis C. And not just treat it, but to cure patients for it. And so the VA contacted every single patient within the veterans healthcare system that we could get in contact with that had a diagnosis of hepatitis C, and we offered these treatments to them. Or the cure to them. And so for the most part, we've cured nearly every veteran in the state of Arkansas from Hep C. And so the pharmacist that was in that clinic was responsible for initiating those medications and managing the therapy and following up on lab rechecks to make sure that their levels were suppressed. Since we've run out of Hep C patients, then she's kind of segued into more advanced liver disease. So patients without Hep C, but they have cirrhosis or they have hepatitis A or B. We don't have a cure for those yet, but we do have one for C. And so those patients are still few and far between. So what she's done, or what we've done, is we've actually created another clinic called a transition of care clinic. And what she does now is she's the liaison between the acute care team and the primary care team for patients that have congestive heart failure or COPD. And if they need an appointment sooner than later, then we can try to get that patient seen by the transition of care clinical pharmacist for those disease state management. All right, next up, we have our medication management clinic. And so formerly called Coumadin Clinic, where they deal with patients on anticoagulation therapy. So they deal with warfarin, they deal with the DOACs, they deal with Lovenox, anything that has to do with anticoagulation or keeping the blood thin so that it prevents strokes or clots or things of that nature. And so they are responsible for managing all those patients in the AmCare setting. If the patient is in the hospital, then the acute care pharmacist will do that management. We won't ask medication management clinic to follow up on the patients while they're in the hospital. I mentioned earlier community-based outpatient clinics. We have quite a few of those. And so I mentioned those clinics in Mena, Mountain Home, El Dorado, those places. And so we have pharmacists located within those clinics as well. And they do the same thing that any other primary care clinic can do. Those pharmacists in the primary care setting, how they work is the primary care provider will diagnose the patient. Let's say they have hypertension. They might initiate a medication, but they only have maybe 2 slots per year for that patient to come back and see that that provider. Well, if you need more intense management and you need more intense follow-up, then that provider can refer the patient to the clinical pharmacist for that management. And so you probably heard of medication therapy management or MTM clinics. It's kind of like that. The difference is that pharmacist is working completely independent. They're not referring anything back to the provider. They're managing it on their own. And once they're done and they've got the patient to goal, or they've reached the maximum efforts that they can give to the patient, they will refer the patient back to the provider. All right, primary care telehealth. And so one of those pharmacists that actually is the pharmacist for one of those CBOCs does everything remotely. So Mina and El Dorado are a little too far away and they're small. And so we don't have the capacity to have a pharmacist sitting in those clinics. And so that pharmacist actually sits in the North Little Rock campus, but they can do all of their work through telehealth. And so that's either virtual, kind of like what we're doing right now, or it's a phone call for follow-up management. And so they can do everything they need to do in those two modalities. Then we have the traditional primary care. So we have pharmacists throughout the North Little Rock primary care who are located within primary care teams. And each pharmacist has 3 to 4 teams that they support. And with those 3 to 4 teams, there's about 3,600 patients for each pharmacist. And so they can go in and find which patients need more tune-up with diabetes management, more tune-ups with hypertension management, who's got cardiovascular disease but not on statins. And so they can find those patients on their own and bring them in, or the patient, if they want to, and say, look, my diabetes is out of whack. I don't know what to do, but that pharmacist was real good at getting me to go. I want to schedule an appointment with them. And the patient can do that. They can schedule an appointment with their primary care pharmacist instead of the provider. So they provide medication management in the traditional primary care setting. We also have primary care with an emphasis on mental health. And so one of those pharmacists does those same things that I just mentioned, but at the same time, when we have patients with mental health issues that are being noticed by the PCP, then the PCP can say, well, I think you're depressed. Let you talk to our primary care mental health pharmacist to see which medication is best to initiate you on for your depression. And the pharmacist will look at their medications, look at other disease states, and figure out what's the best regimen to initiate that patient on. They also will do follow-ups with those patients to make sure that the medication that they selected was the best medicine. All right, next up we have women's health. And so we have a women's health clinic. It's actually located in our Little Rock campus, and they do the same thing that other primary care pharmacists do, but they also do more because they deal with the management of pharmacological issues related to contraception, pregnancy, and lactation. And so we don't deliver any babies here at the VA, but we will care for the pregnant mother as long as we can until they're ready to deliver, and then they have to go outside of the VA system. However, once they deliver and they have issues or concerns with lactation, then the pharmacist within that clinic has a lactation certification, and she can assist with those modalities as well. After that, we've got outpatient mental health. And so I mentioned primary care with an emphasis in mental health. Well, this is the next step up. So let's say we've got patients that are severely depressed. They don't need help with any of the diabetes or hypertension. They strictly need help with their mental health management. And so we've got 2 pharmacists dedicated to a whole comprehensive range of mental health services, and they can assist with that. A lot of times those pharmacists are almost used as psychiatrists in those clinics because they can prescribe and titrate medication. Now, they can't diagnose anything, but they can do everything else. And so the mental health clinics really like having those pharmacists in there because they can prescribe. And so that concludes most of the outpatient or the AmCare positions that we have for the VA, or at least this VA. And so now I'm going to shift a little bit to our acute care clinical pharmacists. So first off, we have our internal medicine pharmacists. And so when you hear about going on rounds with teams, these are the people that come to mind. And so most of them round with medicine teams or hospitalist teams. And we have academic teams that have pharmacy students, pharmacy residents, medical residents, and we have a pharmacist with those teams. Then we have hospitalist teams that don't have any students or any residents. They're full-time hospitalists, and it's just the hospitalist, the pharmacist, and the rest of the team. Every now and then, we may have pharmacy students with that clinical pharmacist, but most students like to be on the academic teams with other medical residents and medical students. It's a little bit more fun, more interactive, a lot more teaching that goes on. And so those pharmacists in internal medicine, they round with the team. They kind of do some of the same things that the AmCare pharmacists do, but they're watching the medications while the patient is in the hospital, and they're making sure, especially if you're on an academic team, that medical resident is watching those blood sugars or watching that blood pressure and saying, okay, you see it rising, what's your plan? And giving them a chance to learn from it and figure out what they're going to do. And so they're serving as a pharmacist attending on that team. A lot of times the attending is either present or not present, but that pharmacist is always present. All right, next up, we have our emergency department pharmacists. And so we've got three pharmacists actually located within our emergency department. And they do the same thing. They provide medication management related services for patients. So unfortunately, a lot of patients don't go to primary care like they should. And so they'll get to the point where, oh my God, I'm out of my blood pressure medication. I feel like I'm having a stroke. And they end up in the emergency department. And so a lot of times those patients are triaged to, is this severe enough to where you need to be admitted? Do you need a physician to intervene, or can you see one of our clinical pharmacists to at least initiate your medication, start something right here while you're in the ER, and then make sure that you go home with at least a 30-day supply of medications, and you need to follow up with your PCP. And so those pharmacists kind of stand in the gap to provide services for medication-related emergencies. Also, a lot of times when patients come in with some sort of infection, whether it's a UTI or a cut or whatever, you know, they'll draw a lab, but the labs aren't going to be back while the patient's still in the emergency department. So they will empirically start a medication on the patient. Once the cultures come back, that clinical pharmacist will see the results. And if the therapy that was initiated is good, they'll let things ride out. If the therapy was the wrong medication, they will enter the proper medication and either have the patient come pick it up or we'll mail it to the patient's home. All right, cardiology. We've got one pharmacist located within our inpatient cardiology team. And so they provide medication management for the acute care cardiology team, as well as our cardiac critical care team. So patients that are admitted with critical issues related to the heart, and that pharmacist helps with medication management for that team. We have a surgical intensive care pharmacy, so our SICU pharmacists, and they provide medication management for patients requiring intensive care post-surgery. Sometimes surgeries don't go well, and there's some, events that require more monitoring after surgery, and so they'll end up in the SICU, and so we have a pharmacist in there. Same kind of goes with our medical intensive care pharmacy, or MICU pharmacists. So they provide medication management for patients requiring intensive care for other medical reasons not related to surgery. Then we have our surgery pharmacist. The surgery pharmacist provides medication management for our general surgery, vascular surgery, and other specialty surgery patients. And so they are watching all those patients on those teams and making sure medication therapy is appropriate for those specific teams. Next up, we've got our hematology oncology pharmacists. And what they do, they review and verify chemotherapy and immunotherapy orders for the outpatient infusion clinic that we have here. They also provide medication management for, obviously, the hematology oncology inpatient team. And so this is our go-to person for all things related to cancer or blood-related issues. So they are the expert within pharmacy service. Next up, we've got our infectious disease or our antibiotic stewardship pharmacist. Now, we only have one of those as well. These are specialty type positions here, and they provide prospective audits and feedback for all antibiotics prescribed to inpatients every day. And so yes, we have pharmacists on all those inpatient teams, and they are just as good at, initiating antibiotic therapy for their patients, but they're not scrutinizing it the way that our infectious disease pharmacist is. And so he's looking every day, he's waiting for those cultures to come back. Once they come back, if anything needs changing, he works in the same office with them. So he really just turns around and says, hey, have you seen the culture come back on Mr. Smith? It needs to be changed to whatever. And so they work really well with the acute care teams to make sure patients are on the appropriate antibiotic therapy. So they're also responsible for developing protocols and criteria to help steer other providers towards appropriate antimicrobial management. Next up, we've got 3 geriatric pharmacists located here in the North Little Rock campus, and they provide medication management for our nursing home care units, our Geri Psych unit, our Geriatric Evaluation and Management unit, as well as our Physical Medicine and Rehabilitation Service unit. And so those pharmacists all of them do the same thing, providing medication management in their respective areas. And last but certainly not least, we've got our pain and palliative care CPS on the acute care side. And so they provide medication management for our palliative care patients. So these are patients that are either in long-term pain or they're not quite ready for hospice. And so we're still kind of managing their medications, but we haven't given up on them as far as giving up on life, where we just provide comfort care. This is one step before we get to hospice. He also does consults for pain management from the acute care team. So if they've got patients on a lot of pain medications and they don't quite know what to do, then they can consult. Our pain CPS for kind of a tune-up in their pain regimen. They also do the same thing, kind of similar to what our antibiotic stewardship pharmacist does in developing protocols and guidelines to help steer those providers towards more appropriate pain medication use. So that was a lot. And so at the end of the residency, or at the end of your pharmacy classroom training, this is how you'll be. You'll be happy, you'll be professional, and hopefully that next step is geared towards doing a residency so that you will have the opportunity to apply for any of these types of positions that I've mentioned above, whether it's here at the VA or somewhere else. So that concludes my presentation. I know that was a lot thrown at you. I tried to keep it as simplified as possible, but I wanted to be able to answer any questions that you all had in regards to clinical pharmacy at the VA.
Thank you, Dr. Brown. So guys, what questions do you have?
Yeah, I've got a question.
Okay, Austin, go ahead.
So that describes a lot of like how clinical pharmacists practice at the VA. I know isn't it federally funded, correct?
That's correct.
And so like, can pharmacists practice like that in the state outside of the VA in similar capacities?
Well, that's a good question. My knowledge is mainly within the VA setting, so I can't answer that completely. I do know that there's some medication therapy management collaborations between pharmacists and some physicians. Matter of fact, I hired one pharmacist from Harding. She was on staff at Harding, and she provided MTM therapy at one of the local pharmacies. And one of the reasons she applied for a job here at the VA was because she wanted that complete autonomy. What she had with the MTM collaboration was more of a protocol. Hey, if you've got a patient on this is your next step. It was really kind of a cookbook type of approach to treating the patient, and she wanted complete freedom. We do work under a scope of practice at the VA. Clinical pharmacists at the VA have been established that we can work under a scope of practice, which means we can work independently without a collaborating provider. Don't know if that's similar outside of the VA? Dr. White, do you know anything differently?
Yeah, so what you're describing is correct. And so outside the VA, you can have, as Dr. Brown was saying, a protocol with a physician. And so, Austin, what happens with that is there are very defined parameters that you can do. It's a bunch of if then statements, right? And so it may be you can manage blood pressure, but you can manage blood pressure with these specific medications. And typically the pharmacist will the physician will start therapy, and then they'll let the pharmacist kind of follow up, as opposed to the VA setting where you have complete autonomy. And so when I was at the VA, the primary care physicians would call me and say, I'm going to send this patient to you for blood pressure management or diabetes management because I can't figure it out. And they would just say, I'll see your notes. I'll keep up with it in the notes. And so I would start, stop, change, whatever. So I had complete autonomy there. But in the non-federal system, you do have a protocol, and those protocols have to be pretty well laid out with what medications you'll use, with what you'll your parameters for monitoring, your thresholds for changing. It's much more restrictive. So that is the beauty of the federal system, is that the federal government, and even stemming back to the military, realized early on that they could use pharmacists as providers as opposed to just filling prescriptions.
Do y'all know if like Arkansas is headed towards that autonomy, kind of like how nurse practitioners grouped together and did that?
So in the state of Arkansas, pharmacists are recognized providers. We are in the statute recognized providers, medical providers. The issue with that is, and this is the issue with, and there are several states where pharmacists are recognized as providers. The issue is payment. Okay. And so payment for pharmacist services that are not tied to a prescription. So payment for pharmacist cognitive services is tied to the federal Medicare statute. So Medicare, CMS, so the Centers for Medicare Services, have to deem pharmacists as providers on a federal level, so that we can be paid for those services even on the state level. And so in the state of Arkansas, you can be paid for your services by private insurance companies. So like, for instance, Blue Cross Blue Shield, Qual Choice, they can say, we will pay the pharmacist for their service. But Medicare statute is really what rules over all of those, including private insurances. They follow what the Medicare statutes say. And that has been the holdup for pharmacists being paid for their cognitive services. I know there was a lot I just told you, but basically, in this state, we are providers. We are deemed as providers. And so we can bill certain insurance companies for cognitive services that are not tied to the product, that are not tied to a drug or getting medication filled. But on a federal level, for pharmacists outside of the VA system, that has been the problem with getting paid.
All right, I see a question where someone asks, you touched on pain management, but I do not recall addiction treatment. Do you have a program with that specifically, or is it part of another position, or is it outsourced? So that's a very good question. So right now we have recruited for a substance use disorder pharmacist. That's a new program that we are starting up within this VA. A sister VA in Shreveport is also starting one at the same time. So brand new area of focus. What we do have is one of our mental health pharmacists and one of our pain pharmacists are both working together with the substance use disorder team to kind of get that up and going, so that once our substance use disorder CPS is on site, then all they have to do is just step into that gap, and they can do it full time, as opposed to our pain and mental health pharmacists just doing it half a day a week. So that's a good question. That's a new area of focus for us. Another question from Hannah. How difficult is it to get a position as a clinical pharmacist on a scale of 1 to 10? All right, very good question. So it depends. It depends on where you are applying, first of all. Since this talk is about clinical pharmacy within the federal system. I'll just speak from that standpoint. I don't know how difficult it is outside of the VA system. So when I first started, way back, if you wanted a clinical position, you could almost get one. Pharmacists were not that gung-ho about being clinical pharmacists, mainly because they didn't want that autonomy and that responsibility, because the buck does kind of stop with you. So a lot of people shied away from it. Now, those who didn't shy away from it were obviously those who had done residencies. I mean, they wanted that to work at that level. They wanted all the knowledge and everything that they learned in therapeutics to be able to utilize it every single day in a specific patient population. So as residencies grew and as clinical pharmacy grew, then getting into the residency program became more difficult. We went from, maybe 20 applicants a year to, where we currently are is over 100 applicants per year. And so as people do residencies, they want a clinical job. And so they're getting those jobs. And so now what the position that I am in, and I think is a great position, is when I post a clinical position, if you have not done a residency, I'm sorry. I'm probably not going to give you that opportunity to even interview when I have people who have done a residency on that certificate. And so that's been an issue. We've got a couple of people that even work here within they've been working here as a staff pharmacist for 5 or 6 years. And now they've decided, I want to work at a higher level. And so they're applying for the clinical positions, but they're not being hired for them. And I can justify that because I can hire the person with the clinical training, with the background and specific to that area. You just being here as a pharmacist does not give you that expertise. So how difficult is it? It's becoming a lot more difficult. If that's something that you're interested in, the first step you kind of starts now with you as a first-year student. When you all have your summer breaks, instead of just chilling at home or deciding you're going to work at your local community pharmacy for 40 hours a week or 20 hours a week, you need to kind of diversify what you do in the summertime. If that means going on a mission trip to do something medication related in Honduras, where you're growing your own medicines and things like that, at least that's something that catches the eye of a residency board. If you're doing an internship with a pharmaceutical company or a nuclear company or something that sets you apart from your classmate, because all of you are going to graduate with the same degree. What else is going to separate you, to me, as a member of the residency board? What's going to make me more interested than your classmate? And so that kind of starts now. So that's the first thing you do. The second thing, as I mentioned, is apply for the residency. And so apply multiple places if you have to. Don't be afraid to leave the comfort zone of Central Arkansas or wherever. There are residency programs popping up everywhere, just like there are pharmacy schools, which is an issue. The pharmacy school part, not the residency programs. We want more residency trained pharmacists because we want clinical pharmacists out there working at the top of your licensure. And the only way to do that is to have more clinically trained people. So scale of 1 to 10, if you got a residency, I'd say 7 or 8 if we have a vacancy. That's the other issue. A lot of people get these clinical positions and they rarely leave. Most of them are happy with what they do. A lot of times when we do have somebody leave, it's because they got married and moved somewhere else. The other instance, I had a clinical pharmacist who was married to a plastic surgeon who opened up his own practice, and she was like, I'm going to sit at home and just have my kids. So, but, I still talk to her and she's like, I miss the work, but I also love taking care of my kids. So that was a life choice that she made. It was not because she didn't like her job.
I would agree with Dr. Brown. On the outside, it's much the same. The hospitals, clinics are hiring residency trained pharmacists. Baptist and St. Vincent, they call us. We have a couple of primary care physicians' offices in the city that have hired full-time clinical pharmacist, so it's the same. And please take heed to what he's telling you when it comes to your diversifying your experiences, your leadership, things of that sort in school. We have both been residency program directors, and that catches my attention. I'm like, oh, this person has leadership abilities, right? Because you have to be able to have that leadership ability, be a self-starter, be able to self-manage in a residency program. And so I would definitely take that to heart. You got some more questions, Dr. Brown?
Okay. Are all your pharmacists at the VA, any pharmacy that works in the hospital inpatient setting, considered clinical?
You answered my question. You
Oh,
called them staff pharmacists. You're good.
all right.
I was wondering if your staff pharmacist down, like if you had it like the other hospitals I've worked at, and you do.
Yeah, so all of our pharmacists are now called clinical pharmacists within the VA setting. Those that do the rounding and working autonomously are called clinical pharmacy specialists. So we've added that distinction in recent years. I mean, everybody with the PharmD is considered a clinical pharmacist. You've mentioned that clinical pharmacist roles have evolved since you have graduated. How do you see the role of clinical pharmacists changing in the future? Well, as I mentioned, they're continuing to grow. A lot of these positions that I listed to you today were not there when I graduated in 2006. Our AmCare has really stepped up a lot. I think we had maybe 2 or 3 pharmacists in AmCare. Now we've got, however many I put on the slide, as well as those in the community-based outpatient clinics. We had some mental health pharmacists that were not, they didn't belong to pharmacy, they belong to mental health. But now, I have meetings monthly with other services that are asking for a clinical pharmacist, services that don't have them, or services that want more of them, specifically mental health, specifically in pain management areas. So that's why this substance use disorder position that I mentioned, we got a grant approval to hire for that. And so they're chomping at the bit to get that program up and going and use that clinical pharmacist for that specific patient population. And the benefit of the pharmacist is, yes, we can't diagnose, but we can do everything else. And since we are the experts in medication, and most pharmacists tend to be a little OCD, then we're going to get that patient back in a lot more frequently than what maybe that mental health provider was doing. And we're a little, easier to talk to. That's why you have, pharmacy used to be the #1 friendliest profession out there, because people like going to Walmart or Walgreens and being able to talk to their pharmacist if they had time to talk to the pharmacist, or if the pharmacist had time. But we're really good with people, but the OCD part of us is what really makes us a lot more attentive to detail and attentive to whatever disease state that we are managing. A lot of the clinical pharmacy world started off in our anti-coag clinic, and they gave pharmacists the autonomy to manage anticoagulation with warfarin. And there are tons of studies out there. You can research them now. Everybody did research projects. There are published studies where a pharmacist managed anticoagulation clinic was much better than a non-pharmacist managed anticoagulation clinic. And so that kind of opened the door to say, well, what else can pharmacists manage better than someone else? And so things kind of stemmed from there. And so we continue to grow. And so if somebody comes to me and they're like, hey, I'm interested in having a pharmacist in my clinic. Well, the first thing I have to think is, can benefit from that, but is it worthwhile for me to put a pharmacist there? And so I want everyone to have one, but I have to be able to justify it as well. So I hope that's a long answer to your question. Clinical pharmacy continues to evolve, and I just can see it. I can see it evolving more and more as we get into areas that we aren't currently located in. All right. For the VA residencies, are they specific to AmCare, acute care specialties, or more geared to practicing in all areas? Very good question. So we have a general practice residency, so that's the first year residency, and so you get experience in all those different areas that I mentioned where we have clinical pharmacy. Well, maybe not all of them, but most of them. And then if you want to specialize, so you can do a second year residency specializing in either AmCare, pain management, or geriatrics. Those are the three that we have here. Now, other programs have other residencies that specialize in other things. And so you'd have to do your research to figure out if you want to do something different in those three, where those residencies are located. Is there also a program more oriented towards work with treating genetic diseases? There may be, but not currently here at our VA. I work in community right now, but thought about going into clinical work. Are there examples of pharmacists working full-time in a clinical setting, but work part-time at Walgreens or Walmart? Yeah, I was an example of that. So was Dr. White. And so when we finished the residency, I mean, we were a little hungry for that money. And we both had families. And so, yes, we would do our clinical work. And then on weekends, or maybe 1 or 2 days throughout the week, we would go and work. She worked at Walgreens, I worked at Walmart. And so, yeah, you can do moonlighting if you so choose to, if there's some availability. Between clinical pharmacists and community pharmacists, is the compensation comparable? So I don't know what community pharmacists are paid at the moment. I do know this past year, we got a pretty hefty raise at the VA. And so I think maybe now the VA might be kind of leaders in pay right now. But Dr. White?
That's correct. It's more. And even when I was there, I made more than the community pharmacist. The VA has pretty much, as long as I have been there, was a little bit ahead of community pharmacy. And then I think even the clinical pharmacists at the other large hospitals systems in the state were ahead as well.
All right. Between, how many PGY1 residents does the VA accept a year? Good question. So I think we accept six PGY1s, and then we've been accepting 3 or 4 PGY2s. I think 2 pain, 1 geriatric, and then 1 AM care. So a total of 10. Let's see what else. So for mental health, a second year residency would be needed to found elsewhere. So I think the question is, if you want to specialize in mental health, would you need to do a residency in mental health? Is that what the question is?
I think she was asking if you would have to do your second year somewhere else.
Right. If you want to specialize in mental health, you would have to do a residency in a place that has a mental health residency. We don't have that here. However, is it absolutely necessary to have a mental health residency? So I am a little critical about hiring a person with a residency for a clinical position. I want you to have at least 1 year residency. If it's a specialized position like mental health, and I don't get anybody with a mental health residency to apply, well then naturally I'm looking at you as somebody who's done, at least a general practice residency where you've at least rounded with one of our mental health pharmacists, you've seen the patient population, you know what's expected, so at least you have a little bit of that experience as opposed to someone who has 0. So I would still consider that. But if you really want to narrow that focus down to mental health, then yeah, you would need to go and do a mental health residency at an institution that has that. Can we really grow medication in another country over the summer? Yes, you can. I've had residents who did a mission trip, and that's what they did. They grew their own Tylenol or aspirin or something. I don't know, but I thought it was a pretty neat story in how they use herbal medications to kind of mimic some of our prescription medications, because those patients obviously can't go to the pharmacy. They grow it right there in their own garden. And I just thought that was really neat. That's like, old school pharmacy, like apothecary type stuff, but in a real rural setting. If we want to shadow a clinical pharmacist to get a better look at the profession, is that an easy thing we can do? Good question. It used to be kind of easy pre-COVID. Now, what's going on with like a lot of my acute care pharmacists, when COVID hit, I kind of didn't want them rounding with the teams. As a matter of fact, the teams kind of stopped rounding. UMS pulled their medical students from the rotations. And when they pulled theirs, then, we were like, hey, what about the pharmacy students? So same thing happened with those students. And then, the pharmacists that round with the teams, they were, a little wary about COVID. And since we technically don't have to be there, we can still see the patient's medical record from our computers. And we have full access to our team via Skype and cell phones and everything else. The question was posed, hey, can we work remotely? And I thought that was an excellent question. And so I submitted to allow our pharmacists to work from home. Initially, it got put on hold because once I asked that question, then other pharmacy services start wanting the same thing. And so, trying to be fair to everybody, is it feasible for those who can to work from home? And then what do we do for those who can't work from home? And so we had to come up with a plan. But eventually, we got approval for a lot of our CPSs to work from home. And so they do a few days from home and then a few days on site. But as far as shadowing, I don't think we're at the point where we're allowing shadowing. I mean, we've just got to the point where we're allowing some of those pharmacists to go back on rounds. Now, I have told them, if you're willing to go on rounds and you're willing to take yourself and your student on rounds, the question's going to come up, what's the point in me getting, keeping this telework going? So there's that balance. And so I know as a preceptor, you want to show the students everything that you can, but we're still dealing with the pandemic. And if you don't have to be in a place, then don't be in the place. So I think shadowing right now is a little iffy, but you can reach out and see if somebody's willing to give you that experience. What about pay compensation between the VA and UAMS? Dr. White?
So the cousins are comparable. Our brothers and sisters at the VA have a similar pay scale to us at UAMS. Now that the VA got their huge bump last year, I was like, really? That's what y'all doing? They have edged us out just a little bit, but it's not a huge gap. But the pay is comparable between the two organizations. We have, as you guys know, we're physically connected. You may not know. So the VA and UAMS are physically connected with a walk bridge, but we share a lot of the same medical staff. And then we share, of course, students across the two campuses. So we have a very close relationship. And typically the compensation is fairly close.
Yeah. Matter of fact,
I think the last question, what'd you say, Dr. Brown?
Oh, I was just going to say, matter of fact, when I was a first-year student, I used to walk across that bridge to work in the outpatient pharmacy at the VA. And if I had a 2-hour or 1-hour break in between classes, that's where I went. And I would get an hour or 2 hours worth of pay and walk on back to class. So,
exactly.
okay.
So Dr. Brown, we have a question. May we email you with questions?
Sure. Yes, you can.
Will you put your email in the chat for them so they'll have it? And so thank you so much for being with us today. You guys were full of questions. This lets me know this was a hit. You guys had all kinds of questions, and I appreciate your questions and you being engaged in the conversation. Dr. Brown's email is in the chat, so you can copy it there and email him with your questions. He is a wealth of knowledge. You're making me miss my family over there. I mean, I'm just like, oh my gosh, I miss it so much. I miss clinical care. I miss y'all so much. I miss the clinical care and patients and the camaraderie of clinical pharmacy. So guys, have a great rest of the day. I will see you all on Thursday. And so I'm going to send out your time assignments that you previously signed up for the clinical skills, the blood pressure and glucose skills lab that we have on Thursday. We're going to use the same times that you guys had. I'm waiting because we may have people that are out ill, and so that may have to change the schedule just a little bit, but you will get that scheduled to you tomorrow to remind you of what time to be there. Don't forget, you also have the ability to get your flu shots before or after your time that's slotted down on the 6th floor right below the Clinical Skills Center. So I will see you guys on Thursday. Have a great rest of the week. Good luck on your exam, and I'll see you guys Thursday. Bye.